Hello and welcome back to the Premier Injuries channel. We've been working behind the scenes on some great content here. And I would say more than just great content, I think very important. As we said at the start of this month, we are doing Movember. You can see my attempt at the moment, and we'll get into if that's a legitimate attempt at all. But really exciting today. We're talking with our newest incumbent member here at Premier Injuries. We've got AJ. And, I'm talking in excited tones, but we will be talking about a serious topic as well. We're going to be talking about prostate cancer because, as we said, we're doing Movember. We're trying to use Premier Injuries as awareness for topics that, maybe sometimes aren't talked about enough in the community, amongst men, amongst friends. And maybe breaking down some barriers because it's important. Premier Injuries is to do with injuries, but injuries can range from, getting a hamstring ping to, depression, cancers, and all these important subjects. So yes, today I'm happy to welcome you on, AJ. We'll be talking about less serious things in the future, but it's great to have you on.
Thank you very much. I'm looking forward to joining you two guys and we can get, a lot of good conversations and important conversations going. So thanks, guys.
No, it's great to have you on. And like I said, you're a new part of the team. Just introduce yourself a little bit then, your kind of links to sport and, maybe who you support as well.
Oh, risky. All right. Yeah. So my name's AJ. I'm a doctor. I work in London. So I'm a junior doctor at the moment, training to be a GP and developing a special interest in sports and exercise medicine. I think that comes from sort of my love of sport in general. And then you can, combine your hobbies and your work and see what you can get out of that. So that's great. And supporting wise, I'm one of the typical Londoners that support Man United. So I think I get a lot of battering over the next couple of weeks, I think.
Oh, goodness. I mean, it's not a good time to be a Manchester United fan. So maybe we can just focus on the injuries and whatnot.
That's safer, I think. That's safer.
Yeah. And I guess with sport as well, then, were you always a big football fan? And this, your growing development in terms of being a doctor, in terms of medicine, was that always something that you kind of pursued from a young age as well?
I think with medicine, I think I knew that I always wanted to be a doctor, which is quite strange. I think going through school and university and things, I kind of just knew that's what I wanted to end up doing. In terms of what I actually wanted to specialize in, and I think probably every doctor's had the same experience, you go through sort of everything in your mind. When I went to medical school, I wanted to be a neurosurgeon.
Oh, wow.
And then I actually started doing, neurosurgery modules and things and realized that it's not really for me. So I think it just depends. And across the way, medical school, through all your rotations, through your different jobs, you start to learn what you like and what you don't like. And I think I just naturally ended up with sports and exercise medicine because it's what I like to do.
Well, it's great that you've made that journey because you're a great addition to the team and we're going to be working with you a lot over the coming weeks, months and through the year. But we are talking about Movember. Before we get into the very serious topic of prostate cancer, we do have to talk about our beard attempts. I mean, AJ, you're new here. I don't know if you're going to be a cat amongst the pigeons already. By kind of deciding, but off air, Ben and I have had a very heated debate. He reckons that this, which I think looks, not the best in comparison to my usual, I would call designer stubble, looking really, really chic and fashionable. But I've done this kind of goatee style, but he reckons it's not good enough for Movember. AJ, you've got maybe the casting vote. Maybe we'll put it to the listeners as well. Maybe put thumbs up, thumbs down, comments below. But yeah, what do you think? Does this count?
On closer inspection, I think you're safe. You're safe. You've got my vote. I think this counts.
Yes.
I think it counts.
Oh my God. For a second now, I thought you were going to say on closer inspection, I think not. Ben almost had that there.
Yeah, I know. I heard him. I had you on your toes there, but I did hear Ben thinking he was going to steal.
That was a false sense of security there.
I mean, that was genius from you, AJ. I think I like you a lot already. We're going to go into it though, the analysis. Like we said, we're talking about prostate cancer here today. Make sure to subscribe to the channel because we've got a lot of other important topics from health experts over the coming weeks about these topics, because it does affect the age group of people that we're talking to. Statistically wise, people listening today are around about the age group that will be affected by this. I mean, AJ, do you want to open out and maybe explain what are the biggest factors when it comes to this? Because I've heard that it's age, to do with family history, and also ethnicity as well.
Yeah, so that's correct. So when we're thinking about risk factors for prostate cancer, we're thinking about three main factors. So one is age. So age 50 is the age that we think about. So you start to think about prostate cancer when you're over the age of 50. The second risk factor we think about is ethnicity. So Black people are more likely to have prostate cancer. And along with that, you would then think of age 45. So if you're Black and 45, that is your risk, that's your risk area. And then the third one we think about is family history. So if you have a brother or a father that has had prostate cancer, that increases your risk by 2.5 times. So you're 2.5 times more likely than someone who hasn't had a family member that has had prostate cancer. We don't really know the reasons for that, but those are the three sort of main factors that we look at.
And you have actually done a little bit of research on this, Stone. You wanted to bring in somebody into the ring here, Paul Parker, didn't you?
Yeah, I was looking at Prostate Cancer UK website and saw the figure that 1 in 4 Black people, which is twice the rate of men generally, get prostate cancer, and I was sort of gravitated towards that and maybe wanted to understand why, and obviously being from sport and Paul Parker, it was a name that I can relate to. And Paul Parker is involved with Prostate UK on a project called Profile. And as AJ alluded to before, the long and the short of it is they don't really know why Black men are at increased risk. And it's a study, it's a UK study, the first of its kind, to try and find out and understand why Black men are more susceptible. So, they're looking at, and we provide all of the links in the comment boxes and in the description. So if you are within, that their sort of remit to be able to register and take part in that course and help people understand, the reasons and the whys and the wherefores, it's definitely worth a look. And, they cover some really good research in, and they're going to do some groundbreaking studies to try and identify, like I say, and understand the disease a little bit more.
And another point that I wanted to bring up, kind of maybe adding to that point, Ben, is it's not just men who have who can get prostate cancer, is it, AJ? It's when we talk about this, it's people with prostate. So this does include trans women, non-binary people, and some intersex people as well.
Yeah, that's correct. Yeah, so it's important with these topics that we are inclusive. So I would say that the list of people that can get prostate cancer, as you rightfully touched on, would be men, would be trans women. So that's someone who was assigned male at birth, but identifies as a woman. That's because when you have your sort of genital reconstructive surgery, you don't, and some people, not everybody has that, but if you were to have a genital reconstructive surgery, the prostate doesn't get removed. So at all times, trans women will still have their prostates. You have non-binary people who are assigned male at birth, and you have some intersex people as well. So it's important that we think about all the people that can have prostate cancer so that we don't miss or exclude a group of people that we need to think about.
Yeah, because it's kind of linked to breast cancer as well. Quite often people associate breast cancer as being with women. And I think, again, you're the expert here, but I'd be right in saying that it affects mostly women, but there are some cases where unfortunately men don't realize that they also do possess breast tissue. And I think it's an important topic, or a situation where everybody who can be affected should know about these. So I think let's bring it on. Oh, go on, AJ.
No, I was just going to say, absolutely, that's absolutely correct. Everybody who can be affected by these issues should be aware of them. I agree with that.
Yeah, and so I think one of the biggest important points then is maybe moving from just people who can be affected, but how can we tell that we might have been or are currently being affected? So what are kind of signs, symptoms that people should be aware of, and then maybe go and ask for help?
Yeah, good question. So the prostate it's a tricky one, because I think probably the best way to explain it is just to very briefly tell you what a prostate is. And then I think if we sort of build through it, it will make a bit more sense. So imagine a walnut. So prostate is essentially a walnut shape and size, and it sort of sits behind your bladder, and your urethra, so that's the tube which you pee out of, runs through the prostate. The reason that's important is because all the symptoms of a prostate that doesn't function properly are related to how you wee, how you pass urine, essentially. So if you think, I mean, I don't have any diagrams, which is a bit annoying, but if you, I'll try and roll up this piece of paper and see. I don't think it will show that well, but imagine you have your prostate like that, right? So that's a circle. You can't see it that well, but imagine you have a circle like that, and you have something running through like that, right? If that prostate is enlarged and it squeezes onto the tube that urine passes out of, you will have problems being able to pass out urine. Does that make sense?
Yeah.
So the symptoms that you get. Say that again.
Sorry, good demonstration there.
Yeah, I should have tried to get more props, but I think I was just off the cuff trying to see if I could make a bit more sense. But essentially, just think of, you know, a tube that is compressed by something. So then, how does that show up? So whenever I explain this to patients, whenever I'm talking to anyone, I sort of walk them through the sequence of going to the toilet. So imagine you have that feeling that you want to go to the toilet. It comes really urgent. So that can be a sign that something's wrong with your prostate, is that suddenly you have this feeling that every time you need to go to the toilet, it's really urgent and you've got to rush to the toilet. So that's one thing. So think about the urgency of which you're feeling that you need to go to the toilet. When you get there, can you pass urine really easily, or do you have to stand there for a while and think, oh, I need to pass urine, but nothing's coming? So that's another thing. When the urine actually does come out, what is the flow like? So because that urine tube essentially is being compressed, the flow is going to be weaker. And then when you finish passing urine, or you feel like you finished passing urine, you then feel like you need to go straight away again. And then if you go away from the toilet, and then sometimes you can dribble. So those are really the symptoms that we're looking at that can start to make you think that you've got a problem with your prostate. So just difficulty or a change in how you pass urine.
And so let's bring it on then to the next stage, which would be screening and diagnosis. And I guess let's throw it to you, Ben, because again, off air, we were talking about this, but sometimes there is fear and anxiety about being examined. I don't know if we want to talk maybe about our differing experiences with prostate examination. Do you want to go first, Ben?
I mean, yeah, I mentioned this off. Yeah, I consider myself to be fairly fit and healthy. Try to leave a really well balanced, healthy lifestyle, and as part of that includes a full annual medical. I'm 44 now, so a few years older than your good self, and almost, I'm outside of that age range. But as part of that full medical history, I was offered the opportunity to have a prostate examination, and I hold my hands up, and I feel as if I'm probably like a lot of people out there. I've mentioned it before, I'm reactionary in terms of, I won't go to the doctors unless there is something wrong. I'll not go to the dentist unless I have toothache. I'm not proactive when it comes to things like that. And I actually declined the offer at that point. More just almost the stigma maybe attached to it, the embarrassment. I suppose there was an element of fear there as well. What if they did find something? A close family friend of ours was recently sort of diagnosed, a few years older than myself, but there's almost that thing where I feel okay, and if I'm getting on with day-to-day life, there's no obvious issues, and so yeah, look, if what I don't know won't hurt me type of scenario. So but in situations like this and conversations that you have, and you understand that you have other responsibilities, 2 young children now, and the identification or the understanding of finding the problem earlier in the process, if that can help in terms of reducing that risk or increasing your chances of full remission, then then that's a decision I'm going to take and make sure that I do get that examination done.
Yeah. So I guess, AJ, is this like a common thing? People fear around it, embarrassment. I mean, is there other reasons as well why maybe people might be put off getting the examination done?
Yeah, definitely, for sure. I think, thanks, Ben, for sharing that, because I think it's important that, if we have personal experiences, to make people understand or to help people understand that they're not alone. It's good to share them. So thanks. I appreciate that, Ben. There's no sort of one way that people react to it. I think Ben used the word reactionary. I think a lot of people are like that. On a good day, they'll do it. On a bad day, they don't want to do it. I think there's a lot of anxiety. There's a lot of lack of understanding about the importance of sometimes having these examinations. So I would say definitely that's a common thing, that people don't really want to have the exam, and you talk to them, you give them the information, and then you let people make an informed decision. One thing that I did want to say, and I think it's important that we talk about this, is that there are sometimes other reasons why people don't want to have that sort of personal, intimate, invasive examination. And it can be that they have been sexually abused as a child or as an adult. And so that's a really difficult experience for them to go through, even if it's with a medical professional. So I would encourage people that if they do have any concerns or any worries or anxieties about having an examination, and we call it a DRE, so a digital rectal examination, that they should talk to healthcare professionals so that they fully understand what will happen, or talk to people who've had them before so that they can share their experiences.
And Ben shared his experience. I do have an experience as well. I'll share that in a second, but I think it's important just to round up there on the fact that there are other reasons why people have this. Is there an option for these people to have a different type of examination to be done, again, to ally fears, that they can go to a doctor and say, I have this, could I be examined in a different way?
Yeah, that's a good question. So there is no other physical examination that you can do. The one that you do to feel the prostate, you actually have to go in and just feel the prostate. So examination wise, that's the only one that you can do. But as we'll talk about, I think, as we go through, there are lots of different things that make up prostate screening. And I say screening because there is no screening program, but just in terms of examination and thinking about if somebody does have a prostate problem, there are lots of other things along the way. So it's not all about the examination. So it's important that people understand that if they feel they have a problem, but they don't want to have a physical examination, that's not the end of the road. There are other things that, we can discuss and do.
Yeah. And so I guess, we're being candid here because, again, I think this is really important to talk about topics. And Ben, has talked about his, I'll talk about mine. And then AJ, you've been almost on the other end where you have been examining people. But with my own experience, it's almost the opposite to Ben, where I was told you know, that I wasn't feeling particularly good, and you know, I had medical problems relating to that, and so they said, well, we have to test for that just in case. And I was in the doctor's office, and so my reaction immediately was, all right, we'll just go for it, because you know, I didn't really want to think about it and say, oh well, I'll do it in a few days, because I kind of almost instinctively knew with my personality that I would lament and worry about it, and then when that came a few days later, I might cancel or whatever. So I just kind of went, we'll do it right now. And I was shocked at how almost fine it was. It was a little bit uncomfortable, and you know, an odd, unique feeling. But afterwards, you know, I felt a lot better, in the sense that I then had an immediate kind of reassurance. There's nothing wrong with yourself, and so the kind of potential anxiety that I could have had over thinking about the exam was way outweighed by the fact that they said you haven't got that illness. So that was one thing that I would say. It doesn't feel as bad as you think it will. It's kind of one of those situations where the longer you think and build it up in your mind, it seems much worse. And so I was lucky in that sense. And now I know every time that I go there, it's uncomfortable, but it's fine. And I guess from your experiences performing this on people, do you kind of find that people often go, oh, that wasn't as bad as I thought it was going to be?
Yeah, sometimes, or you get scared that they're going to punch you in the face. But you know, as I said before, you know, there's no right or wrong way to feel about it. I think the most important thing is that whatever you are feeling, and actually it's probably, you know, it's our job, it's, you know, healthcare professionals' job to make people feel comfortable enough to really voice their opinion on how they're feeling. But yeah, so.
Yeah, and I think we're almost lucky in a sense that we've got all sides of the story covered there, because whatever your reaction is, it's right for you. And so from me saying that I have had it and it was all right, I don't want to make people feel that you should definitely do this and feel bad for not. I'm just kind of explaining that, you know, me as a person that does get anxious sometimes, that kind of worked in my favor. Ben had a different experience, and you, AJ, have experienced it on behalf of people many times, and so you're kind of explaining it from a medical healthcare perspective.
Yeah, absolutely.
Yeah, and I think that's informative. So the next bit is maybe screening, treatment. Do you want to talk us about that, how that process comes about, AJ?
Yeah, so maybe okay, so let's go through a journey. So as we spoke about before, we've spoken about the symptoms. So, you know, you're having problems you know, passing urine, so you go to your doctor. As we said, one of the options, or, you know, one of the things that they will talk about is doing a physical examination. So that's the DRE that I spoke about, so the digital rectal examination. When you do that exam, essentially you're thinking about three things, or we're thinking about three things, which is that prostate a normal size, and is the surface of it, does that fit what I would expect from this person? And that would be ethnicity and age. Is it normal size? Is it larger than I expected for the age? Or is it hard or lumpy? The reason that the size matters is because as you get older, your prostate gets bigger, and that's not abnormal. So you might have some prostate symptoms, but that doesn't necessarily mean that you have prostate cancer. It might be that your prostate is just getting naturally bigger with age, which is normal. Does that make sense?
Yeah.
Yeah?
Yeah.
Yeah.
So that's the first bit. So after you have the physical examination, or instead of, you know, something along those lines, you have a blood test called a PSA, a prostate specific antigen. Now, this test is, I'm not going to use the word controversial, but I think this test is, you have to take it in totality with everything else. So this is not a blood test that you make decisions just off of it, right? So the PSA is, or the prostate specific antigen, is a protein. It's released by the prostate, it's found in your blood. So the bigger your prostate is, the more PSA that you'll release. As because you have a prostate, it's normal that you will have some prostate specific antigen in your blood. So the presence of it in your blood is not a problem at all. I think if you are under 50 and your prostate is normal, you'd expect about a level of 3, and then 3 nanograms, and then every 10 years I think it grows up by 1, so 64, and so on and so forth. Where it becomes a problem, or where it makes us think about if something else is going on, is if we are seeing numbers outside of keeping with the age. So if you are, let's just say for argument's sake, if you are 45, if you are Black, 45, and you have a PSA of 6, that starts to make me think, okay, is there a problem here that we need to investigate? Because at that age, I would expect your PSA to be 3 or less. Does that make sense? Yeah. Fine. So I think, so that's the sort of next stage of diagnosis. As I said before, where it gets tricky with the PSA is that there's lots of things that can increase your PSA. So any problem with your prostate can make that blood test high. So if you have an infection of your prostate, if you just have an infection of your kidneys or your bladder, if you've done really vigorous exercise, if you've had any sexual activity that results in ejaculation, or if you've had any anal sex or any prostate stimulation. So essentially anything or a lot of things can increase the PSA. So you always have to do that test in keeping with everything else. Yeah. And I think because of that, I think that's partly why there isn't actually a national screening program, because the PSA test alone can't tell you whether or not you have prostate cancer. Lots of men with a raised PSA level don't have prostate cancer, and some men with a normal PSA do have prostate cancer. I think the statistics that, I've been through all of this, and, have to explain it to patients, on a regular basis. So I think the statistics are something like 75% of men with a raised PSA don't have prostate cancer. And about 14% of people with a normal PSA will have cancer. So you can see that it's not a perfect test. It's just you take it in totality with everything else.
So what happens after that then? Is there biopsy taken from the prostate? I mean, how do you proceed further to getting a diagnosis and then moving on to treatment?
Yeah. So there are essentially 2 things that you can do, and most people will have them. And I think every hospital is slightly different. And over the years, I mean, some hospitals are a little bit more advanced than others, but generally the system is that if your doctor feels that if your GP feels that there is a genuine prostate problem here, it is possible that you go on to have an MRI. So an MRI is essentially a scan that uses magnets to give you a really detailed image of your prostate, and it will show up, or it can show up, if there are any areas of abnormality in your prostate. After that, you can then go on to have a biopsy, and the biopsy will get some tissue from the prostate to be able to take to the lab, so that we can so that we have more information on what we're dealing with. Is it a cancer or is it not a cancer? So those are the 2 main things, is an MRI and a biopsy. There are different ways that you can do the biopsy, but I think that's a bit too technical. But essentially, those are the 2 things that you would do: an MRI and a biopsy.
And is this, we're talking quite at length here, and there seems a lot is going on. But is this done over a very quick time period? Because obviously with cancer, time is of the essence. So what would be a usual time period of this to happen in? So
anytime that we feel that someone is at risk of a cancer, and it needs investigating, we refer on something called a 2-week wait pathway. So if you've ever heard anyone talk about a 2-week wait, that's essentially the cancer pathway. So the aim is to try and have all of these different steps done within 2 weeks.
Fascinating, and I think useful as well for people to know about this. Final thing with this stage of the discussions is, what is the treatment then if unfortunately you are found to have cancer of the prostate? what is the options for you?
That depends on how advanced your cancer is. So simply put, you can have cancer that's just in the prostate. You can have cancer that is spread to just outside of the prostate, or unfortunately, you can have cancer that's actually spread to other parts of your body. So bone, for example, is a common place that prostate cancer spreads to. If the cancer is just in your prostate, you can have surgery to remove the prostate, or you can have radiotherapy, which is essentially high energy X-rays will be targeted specifically at your prostate to kill some of those cancer cells. Normal cells will recover, but your cancer cells won't. And then you can do something called brachytherapy, which, easy way to put it, is you inject some things into your prostate, and over a long period of time, they will kill the cancer cells. Those are your three mainstays of cancer treatment for cancer that hasn't spread all through the body. If cancer, and that can get rid of the cancer. If cancer has spread around your body, unfortunately, then you'd be going for chemotherapy. So that won't get rid of your prostate cancer, but it aims to shrink it and slow it down.
Okay. And so I guess a positive that we can talk about now is survival rate, because this is actually quite good. It's one of the highest among cancers.
Yeah.
And like I said, is it something that when you find it earlier, as we said here, the speed is of the essence. We're taking our time talking about this, but speed is of the essence. The quicker you have it, the higher the survival rate.
Yeah. So, prostate cancer is a difficult one because, as we've said before, there are lots of things that can give you prostate cancer type symptoms, but are not prostate cancers. So early diagnosis, so you can have early diagnosis, but you also have to be careful that we're not looking for things in places that it's not, if that makes sense, right? But as you did say, you're correct. If you catch it early, so if you catch it early and you treat it, you do have quite good survival rates. So the survival, I think the statistics from Cancer Research UK for England and Wales from 2013 to 2017 is that the 1-year survival rate was about 97%. The 5-year survival rate was 87%. And the 10-year survival rate was 78%. So the survival rates when treated, when diagnosed and treated, are good.
And, this is why we wanted to talk about it, because time is of the essence. I know we keep repeating it, but, if you do think that you've got any of these symptoms, go see your doctor. As we said there with the examination thing, do talk about your anxieties and worries, because they can help you in other ways that maybe if you don't want the digital rectal examination, then you could have something else instead. One of the final things when it comes to cancers and any sort of illnesses, really, when Ben and I talk about, it seems silly in comparison, but, something like a hamstring injury or something, we talk about prevention. What can we do with our lifestyle to stop getting prostate cancer? Or is that not something that applies to this type of illness?
Yeah, as far as research shows so far, there's nothing really that can prevent prostate cancer. I think the most important thing is what we're doing now, which is getting as much information as you can, sort of being honest with yourself, trying as best as you can to not ignore symptoms, but at the same time not to panic about it. I think that's really important. If you are experiencing symptoms, talk to your doctor and then take it from there. So don't hide a fear that something's going to be really terrible, because as we've said, if you catch these things early, you can deal with them earlier. So it's just about, being in tune with your body, understanding what's going on, just being open and going to the doctor and saying, I'm experiencing this, what do we need to do? And then just go from there.
Well, I think, unless there's anything you want to add, AJ, but I think we've covered all that we need to today in terms of prostate cancer. Like we said, we'll be covering some other issues as well. Mental health and testicular cancer are also on our checklist, because all through this month of November, we're talking about Movember topics, very important for men's health. And like we said, please do donate. You can donate to our Movember, or you can donate to any sort of cancers or men's health charities, or just mental health in general, because we want to help everybody and anybody. We're not too worried about the gender of the individual. We're worried about helping people out. Do subscribe to the channel just for information, because there's good stuff in terms of Premier League, Fantasy Premier League, all that sort of stuff, but we're also here to give important information on other topics as well. Earlier in the season, we talked about heart problems. We had Dr. Sadi Raza, and we talked about CPR. So we have that. We will be covering other topics very soon as well. And get yourselves checked if you do have any worries. But for now, I'm going to say a huge thank you for your time, AJ. We'll be seeing you more often. And please do tune in for another special very soon with AJ, with Ben, and we'll be talking about other important topics soon.